Hello, my name is Mitchell Parrish, and this is my case presentation. So today we're looking at my patient that I've been seeing at Peak Physical Therapy and Wellness in Highlands Ranch, Colorado. And the objectives of this presentation include describing the presentation of symptoms for a patient recovering from a total knee arthroplasty, explaining research on rehabilitation as it pertains to patients following a total knee arthroplasty, understanding the current best practice guidelines for developing and implementing a plan of care, the layout of the treatment plan and progress that the patient made during the treatment time, and utilize the LEFS outcome measure to analyze outcomes. So the patient we are analyzing today is my current patient, who I'm calling Lois Lane. She is a 62-year-old female from Littleton, Colorado. She is a certified CPA working from home. Her chief complaint at the first visit was pain with all functional activities, and she described the reason for undergoing the surgery is that she started having pain earlier in the year, and her knee swelled to the point where she couldn't straighten it. And this was after a while of her activity level decreasing. Her past medical history includes a bilateral total hip arthroplasty, the first one being 8 years ago and the second one being 4 years ago. She's had 2 previous surgeries on the right knee, including a plexic excision and a lateral release that got infected when she was 27 years old. The patient rated her current health as excellent and denied any other medical problems and pertinent health issues. Prior to the total knee arthroplasty, the patient was active in the community and loved to play golf. Our goals for Lois included the ability to ambulate 100 feet without pain, ability to ascend and descend stairs without pain, the ability to transfer from sitting to standing without pain, and the ability to get up and down off the floor without pain. These are very basic goals, but that was the reason behind them. We wanted them to be very achievable and realistic and important to the patient as it relates to her life. For the review of systems, the the following were intact: cardiovascular, pulmonary, neurological, gastrointestinal, bowel and bladder, and cognitive. Following the surgery, the integumentary and musculoskeletal systems were somewhat intact, but the integumentary system showed that she had a bit of swelling and a little bit of redness, but not substantially to the point where we were worried, and no marked increase in temperature and no regal edema, and some tenderness to palpation and pain at the surgical site. She did present with guarding of her quads and hamstrings. She rated her pain at best a 0, at worst 10, and at present 4. This was during the visit, so presently at that first visit, she was at a 4. Her lower extremity functional scale score to start was 16 out of 80. And again, her prior level of function was that she had no difficulty ambulating and no difficulty ascending or descending stairs. For her gait, she had an antalgic gait pattern, which is not surprising given her postoperative status. She used a four-wheeled walker, which is important to note because we wanted her to use that walker to stabilize herself and keep her from losing her balance. So the walker was used for that reason, really. And with regards to the stairs, I put down that she led with her affected extremity when ascending and unaffected extremity when descending. So that's a reverse of the normal gait pattern we teach patients when going up and down stairs. Usually we want them to lead with their unaffected extremity when going up the stairs and with their affected extremity when going down the stairs. She also had a positive patellar apprehension test. For her lower extremity girth measurement, she was plus 3 centimeters at all 3 sites, indicating a bit of swelling. She also started out with 80 degrees actively and 85 degrees passively for her knee flexion range of motion. She started out at 12 degrees actively and 5 degrees passively for extension range of motion. We did not do a manual muscle test for the quads or hamstrings at the first visit due to patient acuity and swelling status. To get a better picture of what we were dealing with as far as the patient, we laid out the ICF model as it relates to Lowe's. So she had, for her body functions, she had impaired strength of the quads and hamstrings and impaired active and passive range of motion of knee flexion and knee extension. She was limited in activities by the inability to ascend and descend stairs, walk 100 feet, and swinging a golf club. Her overall LEFS again was 16 to start out, and her participation restrictions included the inability to participate in a round of golf, go on walks with friends, and go hiking. Her personal factors were that she has good access to resources in her community, a high prior level of function and very active, and she has a very high motivation to return to her prior level of function. The environmental factors include that she has been quarantining due to the pandemic, both before and after the surgery. She has assistive equipment at her home, and she has an excellent support system of family and friends. Our diagnosis is that she presents to physical therapy following the total knee arthroplasty with limitations in strength, range of motion, and functional movements. Our prognosis for her was excellent, given that she has high motivation, a good support system, and a high prior level of function. So, to inform our practice, we did a practice analysis. And meaning we made a PICO question and implemented it via a search of the best current evidence. So our PICO question is, do individuals recovering from a total knee arthroplasty who receive supervision and individualized physical therapy compared to no supervision have improved outcomes as measured by the LEFS. The search for the practice analysis was done on Medline using search terms TKA and strength training, range of motion intervention, and LEFS. And this search yielded 126 results, including 4 systematic reviews that I chose to inform best practice. Not included in this search was the clinical practice guideline developed by the APTA that I will outline in future slides. For the 4 systematic reviews are going to be outlined right now in the article summaries. The first was looked at individualized PT programs, and they found that due to the highly individualized characteristics of the type of exercises given to patients, outpatient physical therapy performed in a clinic under the supervision of a trained physical therapist may provide the best long-term outcomes after the surgery. So I took that to mean yes for our PICO question. And to further analyze best practice for patients following a total knee arthroplasty, I decided to look into the other systematic reviews and see what they recommended. So the second systematic review was done on strength training, and they found that progressive resistance training is safe, but that there's not enough evidence currently suggests that it has an effect before or after total knee arthroplasty. The third systematic review was done on prehab exercise relating to post-op outcomes, and they just didn't have enough evidence and they said there wasn't enough evidence to guide the formulation of a total knee arthroplasty prehab program. And the fourth systematic review was done on resistance training for rehabilitation, but this didn't include total knee arthroplasty. It included chronic low back pain, knee OA, Achilles and patellar tendinopathy, anterior cruciate ligament reconstruction, and hip replacement surgery. And they found that resistance training is beneficial for these populations. So to further inform our practice, I went to the APTA clinical practice guideline library and looked up the one on total knee arthroplasty. And these are what they recommend to include in the program for rehabilitation: resistance and intensity of strengthening exercises, neuromuscular electronic stimulation, motor function training, cryotherapy, postoperative knee range of motion exercises, and properly dosed physical activity. With regards to postoperative physical therapy supervision, their opinion is that supervised physical therapist management should be provided for patients who have undergone total knee arthroplasty, and the optimal setting should be determined by patient safety, mobility, and environmental and personal factors. So using all that evidence and combining that with the presentation of Lois, we developed an intervention. So our intervention consisted of 13 PT sessions by the end of my second clinical rotation. Our primary focus was restoring active range of motion of knee extension and knee flexion, because that will give her the ability to meet our goals of reciprocal gait, demonstrating reciprocal gait while walking for 100 feet without pain and going up and down stairs without pain. The secondary focus for our intervention was on pain reduction, gait, stair climbing, and other functional movements. A caveat to this is that the patient is currently enrolled in a study that's analyzing treatment outcomes following a total knee arthroplasty. So she was given a standardized home exercise program That consisted of the following for the first 4 weeks. And then in weeks 5 through 7, these exercises seen here. For the first visit, we mainly worked on soft tissue mobilization to decrease pain, and we did this with passive range of motion into knee flexion and extension. The therapeutic exercise we did included heel slides, wall slides, floor scrubs, knee extension with props, quad sets, marching, and sit to stand. We also had ice with elevation for 10 minutes following therapeutic and manual treatment, therapeutic exercise and manual treatment. For the visits following this, every single visit started with this soft tissue mobilization to the right knee due to its ability to warm up the muscles and decrease pain and tension felt. Ice with elevation was usually included at the end of the visit for future visits as well. So for visit 2 and 3, it started similar to the first visit, and visit 2 had nearly identical therapeutic exercise, but also introduced long arc quads. For the third visit, we started the same and then moved on to 10 minutes of rocking, which is just a light range of motion on the bike and not going in a full circle. We also did the wall slides, walking, standing, marching, and mini squats. So for progress in week 1, she stayed the same with active range of motion and flexion and extension, but improved in passive range of motion for both flexion and extension. She, from this point onward, was able to stand for 5 minutes without increase in pain and was able to weight shift without significant pain. For sit to stand, she was only able to do it 4 times, and we stopped her at 4 times because pain increased quite a bit. She was also unable to put the appropriate amount of weight through her right lower extremity when transferring sit to stand. In this corner, I have these symbols that'll indicate that'll indicate whether active or passive range of motion or another intervention was effective, if it made it stay the same, or if she regressed compared to the previous visit. So in visit 3, she improved again on active range of motion, but stayed the same in passive. She improved in active range of motion for extension, but stayed the same in passive. She stayed the same in passive and active range of motion for flexion. We noted that she was nearing full extension, showing better quad control, and had less discomfort. For the second week, visits 4 and 5, we started out the same for both visits. And in the fourth visit, we did quad activation 10 times 10 seconds with grade 1 mobs to be ephemeral, anterior to posterior. We included 10 times 10 seconds of active assisted wall slides, heel slides and supine, stepping over cones, 5 minutes of walking, standing, and then 2 minutes of marching, and then 2x10 squats. We had a very similar therapeutic exercise for visit 5, but also included 10 times 10 seconds of contract, relax, into knee flexion. So this is a great way to isolate activation of the hamstrings, and we used it quite a bit. She improved in both visits 4 and 5 in her active and passive range of motion for knee flexion and extension. She improved in active range of motion with both visits, improved in visit 4 with passive range of motion, but not in visit 5. In visits 6 and 7, we continued with our therapeutic exercise progression with that contract, relax, the supine heel slides, squats, lunges, and single limb stance was now introduced to challenge her balance. She improved to 115 in both active and passive flexion range of motion, and she stayed the same for active and passive range of motion for her knee extension in both visits. It stayed the same compared to visit 6 and visit 7 for her active and passive knee flexion range of motion. Visit 8 and 9 started out with that soft tissue massage, and then visit 8 and 9 also included the contract relax into knee flexion, the lunges, and the long arc quads. In visit 9, we started grade 3 and 4 AP tibiofemoral and femoral tibial mobilizations and knee extension with overpressure. And we added heel tap off the stair to her HEP. For visit 8, she improved knee flexion passive range of motion to 120, and she no longer had any pain with sit to stand, walking, standing, or balance, and the wound was fully closed. For visit 9, she improved her active and passive knee flexion range of motion to 125 degrees. Her pain rating improved to 1 at present and 4 at worst. Her LEFS improved to 40, and her girth measurements improved to only +1 centimeter. We measured her quad and hamstring strength during that visit. She was able to achieve a anterior step down of 4 inches, and one leg stance eyes open was 20 seconds, one leg stance eyes closed 15. For visit 10, we continued with our mobilizations and soft tissue massage while progressing exercise into terminal knee extension with the squats, lunges, and heel taps. In visit 10, she showed 130 degrees, which is improvement in active and passive knee flexion range of motion, but regressed in knee extension active and passive range of motion. Visit 11 mainly focused on soft tissue massage and ice with elevation due to the fact that she reported increased pain and swelling since the previous visit, and she stated that her pain levels were pretty high, so we didn't want to push her any more than she could handle. Her active and passive range of motion improved since visit 10, but still it's not reaching that 1 and 0 that it was previously getting to. In visit 12, we worked on mobes again, just trying to get back to what we were doing since she had less pain than in visit 11, and we did some light exercise. Since that 11th visit, she improved in both knee extension and flexion range of motion, both actively and passively. And we educated her again on modifying her exercise program to keep the pain level down and keep on activating muscles. So the 13th visit, we got back to what we were doing at about the 9th and 10th visit as far as mobilizations, and we got back to the TKEs and given her more challenge with the long arc quads. She decreased a little bit in knee flexion active range of motion, but not too significantly. She's still doing good at around the 130s, and she's doing good with knee extension active and passive range of motion. And she responded well to decreasing her exercise load. So, over the treatment timeline, we wanted to analyze how she improved over the treatment timeline via the LEFS. She improved by 34 points from weeks 1 to 4 and 10 points from weeks 4 to 7. The detectable change and minimum clinically important difference are both 9 points for the LEFS, meaning that she improved both times by a measurable amount of change, a significant amount of change, and a clinically important amount both times. So I analyzed how her scores had progressed in comparison to a cohort from a study. Kennedy et al. Was the study. And you can see that she's a little bit below at week 1 and doing better at both week 4 and 7. So through my presentation, we have described the presentation of the symptoms for a patient recovering from a total knee arthroplasty. We've explained the research on rehabilitation as it pertains to patients following total knee arthroplasty. We've showed understanding of the current best practice guidelines for developing and implementing a plan of care. We've laid out the treatment plan and progress that Lois made during her treatment time, and we've utilized the LEFS outcome measure to analyze her outcomes. So a quick check for understanding. What is the MCID and MCD for the LEFS? So that would be 9 for both of them. That'd be B. So which of the following interventions is not considered best practice for rehabilitation following a total knee arthroplasty? And that would be continuous passive motion devices. So as far as take-home points, I found that it's really important to check with the patient every visit to monitor their response to interventions. And that'll guide your plan of care, really. You have to adapt your plan of care to how they are presenting each time. If they are feeling more pain and more swelling, then maybe you have to dial it back as we did. And if they're feeling good, then you can progress. I also found that it's important to utilize all the resources available. You need to look into strength training, balance training, range of motion training, all of these facets when developing a plan of care. Here are my references, and thank you.